Okay, well, good evening, everyone. Again, thank you for being here today. My name is Savina Chacheva. I'm the program director at the Cancer Wellness Center. This evening, we're really excited to learn about updates to treatment in colon cancer with Dr. Matthew Adis, who will share more information with you shortly. For those of you who are new to the Cancer Wellness Center, I just would like to take a minute to share more about the organization and the work that we do here at the center. The Cancer Wellness Center was founded in 1989 as a nonprofit organization with the mission to improve the physical and emotional well-being of those impacted by cancer and their families. Our services, which are both virtual and in person, include education programs like the one this evening that aim to help you navigate the varied challenges that come with living with the cancer diagnosis. Wellness classes like yoga, meditation, nutrition, and more that provide a holistic approach to healthy living, and support services which include counseling for individuals, families, couples, children, and those bereaved, as well as support groups that are designed to help our participants manage the mental and emotional impact of cancer. If you would like to learn more about the center and connect to our free programs and services, please visit cancerwellness.org, and I'll put the link in the chat here shortly. Now, without further ado, I'd like to welcome Dr. Adis tonight. Thank you,
Good
Dr.
evening, everybody. Hope everyone's having a good night and everyone made it safely before the rain started. I literally got home about 10 minutes ago and it's now pouring rain. So I think it may be 50-50 whether we lose power, but I'm optimistic that we should be okay. So for those of you who do not know me, my name is Matt Adis. I am a GI oncologist, and I've been practicing at the Kellogg Cancer Center for the last 18 years, predominantly at Highland Park Hospital and also at Glenbrook Hospital. I'm also the medical director of the Kellogg Cancer Center at Highland Park, and my area of focus really, about 80+% of my practice is focusing on GI malignancies. And tonight, my plan is to give you an update of where we are in the management of colorectal cancer in 2025. Um, I really want to kind of give you a sense of how things have evolved from when I started 20 plus years ago to where we are now. And, what started as more of a generalized treatment of disease is now very specialized. I am only going to focus on the medical management or the oncologic management. There have been a lot of advances surgically. There have been a lot of advances through interventional radiology and liver-directed therapy. Both of those are out of my area of expertise and would take countless hours to get through as well. So I'll limit it to the medical management. And there's also a 50-50% chance that right next door you're going to hear from the newest member of my family, which is Murphy Adis, who we decided to get in the middle of winter, who happens to be a little bit yappy. So if you do hear him in the background, I apologize in advance, but he did help me prepare for this evening. So the topics for tonight, first we're going to touch on, like I said, the evolution of colorectal cancer treatment, where we started with chemotherapy to where we are now with more personalized treatment. I'm going to highlight some presentations that were just given at the major GI oncologic conference in San Francisco in January, GI ASCO. There were some pretty interesting presentations, some of which are treatment changing and we're already implementing in our practice, which I think you'll find interesting. I'm going to touch on a relatively new test called circulating tumor DNA. It really has kind of revolutionized how we practice and how we can manage colon cancer on many different levels in terms of deciding who needs chemotherapy, assessing the response to chemotherapy, and also monitoring to see or make sure that the cancer has not come back or has a chance to come back. And then lastly, we'll touch on the role of immunotherapy in the management of colorectal cancer, and also circle back to a presentation at GI ASCO, which is practice changing on my end. And lastly, the hope is to have about 10, 15, 20 minutes left for some questions if anybody has questions for me. But if there are any questions throughout the presentation, if something's not clear, please feel free to type a comment. Savina has access to them, and she can shout them out to me if there are any questions or concerns. So, what we know is that the earlier we can detect colorectal cancer, the better the prognosis. And this is both for colon and rectal cancer. On the slide, up at the top in the red line is stage 1. That orange line on the bottom is stage 4. And as you can see, as you go down or up in stage, the prognosis decreases. So, our number one goal is to try to find a polyp before it has a chance to turn into a cancer. But God forbid, if we're in this scenario, catch it at the earliest point, because obviously people will do better. So there are many different ways to screen for colorectal cancer. This is kind of a busy slide. All the way to the left is colonoscopy. Then you have the fecal occult blood test. You have CT colonoscopy. And what I really want to point out is the purple lines in each slide. The purple line is the sensitivity for detecting colorectal cancer with each of these tests. So all of these tests do a relatively good job of identifying individuals who have colon cancer. Colonoscopy clearly, by far, in a way, is the best test. But there are certainly barriers to colonoscopies, as we all know. Number one, there may not be enough GI physicians to perform the test in all the patients who need it. And frankly, the prep for colonoscopy is not the most pleasant. So a lot of people are adverse to have the colonoscopy done. So with these other options, they're decent tests. But if they are abnormal, you're still going to have to go back to the gold standard, which is the colonoscopy. So colonoscopies historically were, for patients who had average risk for disease, recommended to start at 50. But more recently, that has shifted to 45, and we'll talk about why that's the case. The incidence and mortality rate of colorectal cancer has been declining in the United States. And since 1990, it's dropped about 50%. And, we believe that's tied into people being more diligent with their colonoscopies, physicians getting more of their patients who need it to get colonoscopies. And I already mentioned, the earlier we can find it, the better the prognosis, the easier it is to treat. And this statistic always astounds me, that we can eliminate 80% of all colorectal cancer if everyone had a colonoscopy when it was recommended. And that's just a statistic that 20 years ago blew my mind, and it still does to this day, because I obviously see this on a day in and day out basis. So as we get older, the incidence of colorectal cancer increases. But it's really been interesting, because what we've found is that if we break down the age group 55 and older compared to 55 and younger, the incidence of colorectal cancer in the older population is actually downtrending. But in the younger generation, in the younger population, the incidence is shooting up at an astounding level. And there are reasons for this. So, we believe it's a combination of both genetic influences and environmental and lifestyle exposures. Certainly, hereditary colorectal cancer syndrome plays a role. 35% of all colon cancers in young adults is because people have a hereditary predisposition. But the metabolic portion of it plays a big role also. High cholesterol, high blood pressure, an unhealthy diet, high red meat intake, decreased exercise. All of this can lead to an increase in risk for colon cancer. Back to the genetic portion of it, we know that people who have a first-degree relative with colorectal cancer are at a higher risk. Patients who have a very high intake of alcohol also are at a higher risk. And lastly, what we found is that people who are vitamin D deficient may have a higher risk as well for forming colorectal cancer. More clinical trials and more investigation is going on, but this is proving to be something that looks to be a real finding. And anybody that has a low vitamin D level, we certainly recommend that they treat to an adequate level. So how has treatment evolved over my career? I can distinctly remember back in the late 90s, I was at Loyola, and a doctor who ultimately became my mentor, a phenomenal GI oncologist by the name of Alex Hantel, who at the time was also the head of the cancer center at Edwards Hospital, gave a talk called Colorectal Cancer Alphabet Soup. And at that point, the concept was there was really X amount of chemotherapy combinations that we could use that were effective for colorectal cancer. And at that time, our belief was it didn't really matter which one you used because people were going to get every single treatment at some point over the course of their disease. And the order didn't matter. People did better because we had all of these options now, so you could use them over the course of treatments. But we've learned that that's just not the case. And you flash forward a couple of years, and then this whole idea of what's called sidedness came about. And sidedness, as you'll see, is that a colon cancer that starts on the right side of the colon is distinctly different than a colon cancer that starts on the left side of the colon, both in the biology, both in the prognosis, and in the treatment options available to that individual. And that has to do with, and we'll get more into it, where the tumors form and what molecular findings are unique to each side. And now, as we flash forward to where we are now, it's more patient-specific treatment. We treat each individual tumor based off of the molecular makeup of that individual's colon cancer. And, it's far more specific than that one-size-fits-all or that sidedness concept. Now, one thing that we're also able to do now is in certain situations, and we'll talk specifically about this, is tease out who benefits from the chemotherapy and how much chemotherapy do they really need. Because there are scenarios that we can actually limit the amount of chemotherapy someone needs with the same outcome, and that's less toxicity and a shorter duration of treatment, which obviously is an optimal scenario. And then lastly, something I'm not going to get into too much just because, we don't have countless hours this evening. There's been more options, even in the last several years, beyond what I think of as conventional chemotherapy. There are now several oral agents that are available that patients benefit from. And, I see really excellent results in my patients. And, we're learning how to implement these. And now that we have so many options, we're kind of teasing out what's the best path to use all of them. So this is just a slide just to remind me of that alphabet soup, one size fits all. You could see all the way to the left, these are all the regimens that we had back then. This doesn't even tap into targeted therapies like EGFR inhibitors, cetuximab, panitumumab, or VEGF inhibitors like Avastin, but that was all part of that alphabet soup, one size fits all. And now we get to the sidedness concept. And, this splits between the right side of the colon cancers and the left side of colon cancers. And what it comes down to essentially, and what's interesting, is the right side of the colon and the left side of the colon at the level of the embryo develop in completely different areas. The right side develops in the midgut, the left side develops in the hindgut. And as a result, right-sided colon cancers that have developed from the midgut have a different biology. They have a higher propensity to have this thing called MSI, or microsatellite instability, which we'll talk about a little bit later, but that speaks to people who would benefit potentially from immunotherapy. But on the flip side, right-sided colon cancers also have a higher rate of BRAF mutations and KRAS mutations, which are felt to have more of a poor prognostic value and may limit our treatment. And as a result, right-sided colon cancers are often associated with the worst prognosis when compared to the left-sided colon cancers, which don't have those same genetic mutations, the BRAF or KRAS mutations. On the left side, there's also a higher probability of having what's called HER2 overexpression, and that opens up even another option for other therapies that we can add to our war chest of treatments, and that portends to a better prognosis. So it all comes down to predictive biomarkers, finding out as much of the biology of an individual's tumor, because that's going to drive therapeutic decision making. So we try to get gene profiling of tumor tissue right at diagnosis. And at Endeavor, we are able to do this within the hospital. At Northwestern Lake Forest, they can do the same. At every major center, they're able to do this and type your cancer to get that molecular profile. And that really is now the standard of care. And if you're being treated at a center that doesn't have in-house capability, there are plenty of companies out there that can do that for you. And the tumor can be sent to those companies and it can be done. And for example, you could see who's going to benefit from those monoclonal antibodies that target that EGFR. If patients have that KRAS mutation that we just mentioned, they're not going to get that family of medicine. If patients have that microsatellite instability, you'll see that speaks to responding to immunotherapy, and that's a great option. And also that HER2 that I had mentioned opens up HER2 medications that historically had been used for breast cancer treatment, but 3 to 5% of colorectal cancer has HER2 mutations or overexpression, and we're able to implement that, and that could be game-changing in terms of treatment as well. So is colon cancer one disease? I mean, back in the late 90s when I started treating, we thought it was. But we've clearly learned over the last couple of decades that we can break it down not only into these distinct subtypes that you see on this list, but more so to the individual's biology. And that's really how I view it. Each individual has a different diagnosis, has a different colon cancer, and should be treated in a very specific fashion unique to their disease. And you need that molecular information to know what the best treatment's going to be. So we do that through next generation sequencing. And next generation sequencing takes the tumor either through disease that's been removed or through a biopsy. And if you don't have the ability to do that for whatever reason, we can try to get that information through a blood test as well, because sometimes we could pick up cancer DNA in the bloodstream and get some genetic information. It clearly is better when you actually have the tissue. And then you could see these technologies listed here, which give you a whole ton of data analysis. And that gives you the specific molecular profile of an individual's tumor. And that's where we come in and we tap that to figure out what treatment's going to be best. But with the companies that run that test, and this is just an example of a report that we get, it's unbelievably helpful to us. Foundation One has been around for a long time, and I just was able to pull this off the web. So I thought it was a really good example of how I look at a report and how I can implement it in my practice. And this is a patient who had colorectal cancer. They ran the next generation sequencing, and you could see under tumor type colorectal cancer, it says genomic alterations identified. And in this tumor, they had 3 different genetic alterations identified: PTEN, KRAS, APC. And just as important, they said additional disease-relevant genes that were not altered. And in this one, BRAF was not mutated. So if you go to the left, it says patient results. You have these 3 genetic alterations that we identified. And then what they're able to do is really break it down for the doctor to really be able to process the information quickly to make the best treatment decisions. Because you could see underneath that, there's 2 therapies associated with clinical benefits. And if you go down to the therapeutic implications, it says FDA-approved therapies. There's 2 medications that are listed, but you could see that these are listed in other tumor types and not in the patient's tumor type. So we wouldn't use these up front because they're not proven to be beneficial in colon cancer. But if we've run through conventional therapy and we're looking for potential options that someone may benefit from, that may be something to think about because of the biology of the tumor. The next below in patient results are 2 therapies with lack of response. And this is really important for us because that is that KRAS mutation, as you can see, which tells us that panitumumab and cetuximab would not be beneficial to add to this patient's treatment. And in fact, if someone has a KRAS mutation and you add one of those medications, it could actually lead to a worse prognosis for the individual. So you want to avoid that at all costs. And then obviously, we always are thinking about what other options do we have? What clinical trials are available? In these, based off of the molecular profile, these tests are able to then look through and scour all of the clinical trials that are out there and tease out the ones that not only are available, but where they're available. So it helps us get a better sense of, just geographically where people could go to try to get the best treatments possible. So I'm going to shift a little bit into the duration of treatment, and this specifically has to do with adjuvant therapy. And when we speak of adjuvant therapy is chemotherapy that's given to individuals after they've had their colon cancer removed with the effort or hope to improve the likelihood of curing individuals. And the duration is really dependent on the stage of disease at diagnosis. And specifically, when it comes to stage 3, and as you'll see in a couple minutes, I'll briefly run through the stages of colon cancer. Stage 3 is a tumor that has spread to lymph nodes, but that has not spread elsewhere throughout the body. What we're able to do now is differentiate between low-risk stage 3 colon cancer and high-risk stage 3 colon cancer. And what differentiates those two is a low-risk stage 3 colon cancer is one that has not grown, a tumor that has not grown through the bowel wall, and those lymph nodes, there are 3 or less lymph nodes that are involved. If the tumor has grown through the bowel wall, or the tumor involves more than 3 lymph nodes, that's considered a higher risk stage 3. And you'll see that plays a role in determining how much chemotherapy someone needs in that situation. And also, a very important thing that we look at is the presence of microsatellite instability. In stage 2, if you have microsatellite instability, that actually speaks to a much better prognosis. And generally, no one would get chemotherapy if you have a stage 2 colon cancer that's microsatellite unstable. But in stage 3, interestingly, it speaks to a resistance to one of the main chemotherapies that we use, which is 5-fluorouracil. So we want to give a more aggressive combination, adding oxaliplatin to it's called a combination of FOLFOX, which many of you know, because that's needed if you have microsatellite instability in a stage 3 colon cancer. So briefly running through the stages, stage 1 is relatively superficial tumor, no lymph nodes involved. Stage 2 grows a little bit deeper into the bowel wall. You have muscle involvement. Stage 3 doesn't really matter the size of the primary tumor, but there are lymph nodes that are involved with spread of disease. And then stage 4 is when it's spread to other areas of the body. So historically, for stage 2 colorectal cancer, or for stage 2 colon cancer, the prognosis is quite good with surgery alone. You know, the statistics are the probability of cure with surgery is about 80%. And the majority of people with stage 2 colon cancer don't have to have chemotherapy. But we always tried to tease out who we believed would benefit from additional therapy to try to improve their prognosis. And in the past, we looked for what we felt to be high-risk findings that would speak to potentially a higher risk of the cancer coming back. And that has to do with bigger tumors that have grown through the bowel wall, more aggressive appearing tumors underneath the microscope, tumors that have caused holes in the bowel, perforation, or block off the bowel, obstruction, are involved with the lymphovascular system or the nerve system. And if you had any of these, we thought that there was a benefit potentially, not really, you know, easily measurable, but we always felt that those individuals would benefit from chemotherapy. So it was always a discussion, maybe we should consider some chemotherapy, but you'll soon see that there's now a better test that helps us make that decision. So, you know, this is the American Society for Clinical Oncology. It's a very busy slide. It just tells us now that when patients with stage 2 colon cancer come to us, it's not straightforward yes or no. You have to take into the account whether they have any of those higher risk features, whether they have that microsatellite instability, and then it's an individual conversation of whether we believe people are going to benefit from the therapy. But we'll get into that newer test that really is game changing in my mind, that eliminates a lot of this conversation in most situations. I'd mentioned, what about stage 3 in the amount of chemotherapy? And this is where that high risk, low risk really comes in. If you have high risk stage 3 colorectal cancer, you need 6 months of chemotherapy. That's where you're gonna get the highest benefit. There's really no conversation there. That is standard of care. But if you have low risk, and we talked about that being a tumor that didn't grow through the bowel wall and less than 3 lymph nodes involved, we found that we could actually give half the amount of chemotherapy, less toxicity, and people do equally as well. This is looking at the survival curves of 3 versus 6 months of chemotherapy in those low-risk patients, and the lines are absolutely the same. So we're saving 3 months of exposure to medicines that have side effects, And people are doing just as well, which is really exciting for an oncologist not to have to give chemotherapy. That really is the best case scenario for us. So I had mentioned at the beginning, I was going to briefly touch on these new oral options as new standard of care. We have regorafenib, we have fruquintinib, which is one of the newer ones. GI ASCO, which I'm going to get into in a little bit, last year presented what's called the Rainbow trial, which looked at Lonsurf and Avastin combined together. And as of last year, that became a standard of care after we stopped responding to conventional chemotherapy. But now we have obviously multiple options that we can work through, and we're really trying to sort through which is the best one to use after we stop responding to FOLFOX and FOLFIRI and EGFR and Avastin type based therapies. So now I'm going to shift over to GI ASCO from January, and I'm going to run through 4 different things that were presented. Immunotherapy, I'm going to get a little bit more involved in and talk a little bit more about where it's used currently in practice as well. The first is kind of an exciting thing, a blood-based screening test for colon cancer, because at the beginning of the talk, we talked about the fact that if there's a good screening test and we could find colon cancer early on, people will do better. And if there's an easy test that people who are just not willing to go through Cologuard or a colonoscopy prep, this may be a good first step, because if it comes back abnormal, then certainly I think people will be more amenable to getting the colonoscopy they so desperately need. And they presented what's called the PREEMPT colorectal cancer study, where they enrolled 40,000 average risk patients, and the sensitivity for finding colorectal cancer was 81%. And just as important, what's called the negative predictive value, meaning if you had a negative test, we're 90% sure you don't have colon cancer, that's a good place to start and may supplement or be used complementary with the colonoscopy. Certainly further studies are needed, but these are exciting advances that are going on in the management and hopefully prevention of colon cancer. Next, we're going to shift to a very specific situation, and that has to deal with advanced colorectal cancer in individuals who have what's called the BRAF activating mutation. And historically, BRAF has felt to be a negative prognostic factor, meaning essentially, if you have the BRAF mutation, tumors are felt to be a little bit less responsive to conventional chemotherapy, and the disease may act a little bit more aggressive. So on the left side of the slide, you have normal cell growth. And in normal cell growth, we have these pathways within the cell, EGFR to RAS to BRAF, MEK, or if these pathways are running normally, then cells are developing and growing at a normal fashion. But you can essentially obtain mutations in any of these areas that can increase the stimulation of cancer cell growth. And a lot of focus on the management and really where advances have come about is targeting each of these different places. The receptor EGFR, you can give cetuximab or panitumumab. More recently we found with BRAF, we can give encorafenib, and there's a medication, a MEK inhibitor called binimetinib that could be used. And these are kind of changing the paradigm of how we can treat these situations. Because if we could turn off that overstimulation, then the hope is that patients do better. So the BRAF activating mutation occurs in less than 10% of sporadic colorectal cancers. And as I mentioned before, it has a strong negative prognostic marker for both early stage and for more advanced tumors. And I've already mentioned, it's associated with a more aggressive disease course. Interestingly, there's certain tumors that have both the BRAF mutation and that microsatellite instability, which speaks to responding to immunotherapy. And we'll get more into that, the microsatellite instability, in a little bit. But what we found is when tumors have both of these abnormalities, that adverse or negative prognostic in data from BRAF doesn't have the same significance. And we generally see the BRAF mutation along with microsatellite instability in sporadic tumors. You'll see, or the microsatellite instability alone is more commonly seen in the genetic type of cancers. So back to GI ASCO, this was a very exciting presentation. It was the Breakwater study, and in this trial, they took individuals who had tumors that did not have a KRAS mutation, but did have a BRAF mutation, and they separated them out with individuals either got standard of care chemotherapy, and that could have been any of the combinations of what we consider the best frontline therapy. And then it was the standard of care with both the cetuximab, which is that EGFR inhibitor, and also the BRAF inhibitor, the encorafenib. And what we found is that by combining the BRAF inhibitor and the EGFR inhibitor, is that the response to treatment increased by 20%, which is a significant increase. And the number of individuals who were alive 1 year into treatment increased from 66 to 80%. And just as important, the number of people who were responding, that persisted for at least 6 or 12 months. Or I mean, that number actually doubled compared to standard of care chemotherapy. And what we're saying and what we're hoping is that we're going to see a continued trend to improvement in overall survival. The data is very early right now, so we can't definitively say that that's the case. But this is the survival curves. The top blue line is the individuals who got the chemotherapy plus the encorafenib and the cetuximab. And the bottom line is just the standard of care chemotherapy. And you could clearly see that there's a big separation between those groups that seems to be maintained as time goes on. And that's really exciting because you're taking a situation that a year ago we felt was more difficult to treat, and we're really changing how effective our therapy can be. And I think a lot of people are going to benefit from that, which is very exciting. Vitamin D in metastatic colorectal cancer. I had already mentioned that deficiency in vitamin D was felt to increase the risk potentially for colorectal cancer formation. So there was a study that was presented at GI ASCO this year saying, okay, well, what if we do replace vitamin D, but give it at higher levels? Is that going to change prognosis? Are people going to respond to therapy better? Are people going to live longer? And unfortunately, it did not show that there was an improvement in overall survival, but still, I think important data for us to know. So yes, replace your vitamin D, but you don't have to go overboard with the amount of vitamin D that you're replacing with. So now we're going to move on to a newish or newer test that we use in practice, which for me, I think is game changing on a lot of different levels, and is a very, very exciting tool that I'm able to use at just about every stage of management of colon cancer. And the idea between circulating tumor DNA is that you can see on the right, on the bottom, this patient has colon cancer, and the colon cancer is essentially shedding its cancer DNA into the bloodstream. And when you take a blood test, you could detect that DNA in the bloodstream. And it's a powerful tool that helps us at diagnosis. It helps us assess response to therapy. It helps us make decisions, as you'll soon see, on who's going to benefit from chemotherapy or not. And it helps us assess response to treatment and also monitor for relapse of disease. So how do they do this test? How do they make this test? Well, unfortunately, someone's diagnosed with colorectal cancer, and they have a biopsy or they have their tumor removed, and we're able to take the tissue along with a sample of the patient's blood, and we send it to, the company that I use is a company called Signatera, and they're able to develop a specific blood test to that individual's tumor, where then we're able to test that blood from that individual to see if that cancer that was removed is still in the bloodstream. And we're able to then in the future, because they have that test already developed, test their blood. And we could do that as many times as we need to, depending on the scenario. So how do I use this technology in my practice? Well, as you will see, it's very helpful in determining the need for chemotherapy. We talked about stage 2 colon cancer and trying to tease out the more adverse prognostic factors that would make me more inclined to recommend chemotherapy to my patients. And you'll see that this test is really helpful in helping me decide who with stage 2 cancer should get chemotherapy and who should not. In stage 3, it's a little bit more controversial. At the GI ASCO conference, some of the true thought leaders gave a presentation on this, and some of them actually said if someone comes to them with stage 3 colon cancer and they have a negative circulating tumor DNA test, they would not give their patients chemotherapy. For me, I'm not ready to say that that's the standard of care. I still think that there's benefit in those situations for certain individuals. And we just had a dinner with one of the colorectal cancer gurus at University of Chicago, Dr. Blaise Polite, who I work with quite a bit, and we proposed that question to him. We said, if you have a patient with stage 3 negative circulating tumor DNA, are you going to give them chemotherapy or not based off of this test? He said he would not eliminate chemotherapy even if that test was negative. And that's kind of what our thought process is for myself and my colleagues over at Endeavor. I'm also able to use the circulating DNA, as you will see, to monitor how patients are responding to chemotherapy. And I also use it quite a bit to monitor for recurrence of disease. As you will see, it's a really good thing if you have a negative test after you're done with therapy, because from a prognostic standpoint, it puts you in a much different position, and we're feeling pretty good about the fact that we've treated the cancer successfully. If the test is positive, or God forbid it pops up positive, as you're soon going to see, we know the cancer is going to come back, and we know that there's a lag of time before we may see that on our testing through other blood tests or through the CT scans that we use, and we may opt in that scenario to do a little bit more frequent imaging, more so than we would if we didn't have that information. So neoadjuvant chemotherapy, essentially chemotherapy before surgery, allows us to assess how people are responding. And if we find that someone's not responding to the chemotherapy we're giving, may allow us to either shift what we're using or intensify therapy. In the adjuvant therapy, again, chemotherapy after someone's had potentially curative surgery, you'll see it's going to help drive that discussion of who would benefit from chemotherapy. And then when it comes to surveillance, it can help us detect relapse earlier than the conventional methods that we have right now, which is essentially that protein marker CEA in the bloodstream in CT scans. And earlier relapse, catching it earlier detection could lead to better treatment, more aggressive treatment, and potentially even curing people who have recurrence, albeit at a more advanced stage. So, this shows you what it looks like in individuals who have a positive circulating tumor DNA assay test and a negative circulating tumor assay test in terms of the disease coming back. High risk stage 2, the blue line, if you have a positive test, then there's a 50% chance that at least within a year that cancer is going to come back, and you definitely are going to give these patients chemotherapy in an effort to try to get that Signatera test to pop negative after they're done with treatment. If that high-risk stage 2 has a negative circulating tumor DNA assay, you can see how great their prognosis is. They don't need chemotherapy, and they're not going to benefit from it. Why in stage 3, when we move to the middle, I'm not quite at that point to say that a negative test should not lead to recommendations of chemotherapy. Obviously, the people with a positive test, that blue line, we know the cancer is going to come back and they're going to benefit, and we're going to cure more patients by giving them chemotherapy. But that green line, if they're negative, and you don't give them chemotherapy, there's a good portion of patients that are going to recur. And I think that we could change that prognosis and more people will benefit from getting the therapy. So, I'd already mentioned that after surgery, it allows us for better surveillance. And this is just an example that Signatera provides that, after surgery, once patients have surgery, their circulating tumor DNA should go negative. And if we check it every 3 months, then, the negative test you'd expect that when you do CT scans and CEAs, they should be normal. But if that test ultimately does test positive, then ultimately, our expectations at some point are that the disease will recur. And in this example, you could see a little bit after the Signatera became positive on the MRI that we detected that there was a liver lesion. They had the liver resected, and fortunately, after that, the Signatera test went back negative. And in this situation, because the Signatera test went back negative, there's a world that you wouldn't even need any more chemotherapy after having the tumor removed from the liver. But if it remained positive, you may consider giving chemotherapy in that situation in the hopes of getting it to turn negative. So again, same example here. On the left, you could assess the response to treatment before surgery, but after surgery, you should see that blue line go all the way down to the bottom. And in this example, you're monitoring, and all of a sudden the levels of the circulating tumor DNA start to increase. And then shortly thereafter, the patient relapses by imaging. And then you can just assess how they're responding to treatment. Now, the accuracy of the circulating tumor DNA far better than the standard of what we have right now, which is just the protein marker, which is the CEA. You can see the sensitivity is 88% versus 69%, which is a pretty dramatic difference. And I had mentioned previously that once a test becomes positive when you're following someone after curative surgery or curative treatment, that there's a lag from a positive test to when we can detect it on a scan. That lag is generally about 8.7 months. So in a situation where I'm following someone after what I hope to be curative therapy and their Signatera test becomes, if it's negative, I'm going to do CT scans essentially every 6 months. That's just my, my standard approach. But if I'm doing it every 6 months and doing Signatera or circulating tumor DNA tests every 3 months and it becomes positive, then I'm going to switch from CT scans every 6 months to CT scans every 3 months with the hope that I'm catching it earlier so I could be more aggressive in treatments. So how can we use it in clinic? From a single Signatera test, if you have a positive test, 97% of patients with a positive test with early stage colorectal cancer will relapse without further treatment. If you have a negative test, only 12% of those patients will relapse after surgery. So that's important prognostic information and helps drive decisions. And then in individuals that we're testing with serial tests, we can assess how patients are responding to therapy. If you're responding, you would expect the level of the circulating tumor DNA to decrease. Obviously, if you're not responding, it's going to increase. And the more we test and the longer we go on, the more negative tests we have, the risk of relapse decreases down to 3% with serial sampling. So now we're going to move on to immunotherapy. And immunotherapy has really been a game changer for individuals who benefit from the treatment with immunotherapy. And we're able to tease out who would benefit from this treatment. And there are tumors that have what's something called mismatch repair. Mismatch repair is a cell's mechanism for repairing DNA damage. Every day, DNA is replicating in our body, and we have the machinery to, in most situations, fix the damage, and then that way those cells function normally. But if the machinery to fix that damage is not there, or if you have a mutation that doesn't allow it to fix the damage, you get an accumulation of mutations in the tumor. And tumors that have a lot of these mutations enhances the immune system's response specifically to these cancers. The immune system has a better way of identifying those tumors and can utilize, and if we can allow the immune system to attack the cancer, we can treat it more effectively. And this is seen in 3 to 8% of metastatic colorectal cancer. Another way you can look at it is something called high tumor mutational burden, and it's the same idea. More mutations, the immune system's going to recognize it. So if a tumor has either of these, they're going to be more sensitive to immunotherapy or what we call immune checkpoint inhibitors. And this is just a visual of, errors being made in DNA replication in our body. On the left side, you have these proteins, MLH1 and the other three. Those are what we test for to see if someone has microsatellite instability. Those are what we test for to see if people have Lynch syndrome or predisposition to colorectal cancer. And if we have them and they're functioning normally, DNA is repaired. But on the right side, if we're lacking them, one or multiple, then those people are going to acquire mutations in their tumor. And this is kind of hard to see, but this just looks at the number of mismatch repair, microsatellite instability in all the different cancers that we treat. And this just shows that 3 to 8% in the colorectal cancer. So how does immunotherapy work? Well, I kind of think of things very simplistically. Cancer is pretty smart. And what cancer does is cancer tricks our immune system on a daily basis to not recognize it. Because if the immune system recognized the cancer, you'd expect the immune system to say, you shouldn't be there, I'm going to attack you and hopefully get rid of you. And there's markers on the tumor that match up with markers on our immune system that allow the tumor to kind of trick the immune system. We have these immune checkpoint inhibitors that I'll show you in a little bit that allow the tumor not to meet up with the immune system so it doesn't get tricked. And then our immune system, the T cells get activated, and it can lead to the destruction or tumor cell death. So how do we use immunotherapy right now? And we'll get into some examples, but immunotherapy certainly can be used at an early stage. And specifically where it's been game-changing is in early stage rectal cancer. And I'm going to show you some data which is actually pretty astounding. There's a question of whether immunotherapy provides benefit after colon cancer has been removed, and there's clinical trials looking into that, but it's still early in terms of data, so we don't have enough to say whether there's going to be benefit or not. And certainly, as you'll see, immunotherapy has been game-changing in people who benefit from it in a more advanced or the metastatic situation. There are a ton of immunotherapies that are out there right now, specifically for the management of colorectal cancer. The top two on the anti-PD-1, nivolumab, pembrolizumab, are the mainstay. The starlimab, number 4, you'll see is really going to revolutionize how we can treat rectal cancer. And then when you go down to the anti-CTLA-4, ipilimumab is now going to be utilized more based off of data from GI-ASCO. So this looks at immunotherapy compared to chemotherapy in someone with a microsatellite unstable tumor when they have metastatic cancer. And we know that immunotherapy is 5 to 6-fold more responsive than chemotherapy. And this looks at the response rate, and this is just kind of showing 2 years, looking at, in this example, pembrolizumab versus chemotherapy. And the difference at 2 years of patients responding is 85% versus 33%, which is an unbelievable difference, obviously. So, certainly if someone has a microsatellite unstable tumor, standard of care is immunotherapy. So prior to GI-ASCO, I'd been giving everyone pembrolizumab because, patients tolerate it quite well and the response rate's great. Improved progression from 16 months versus 8 months of standard chemotherapy. The progression-free survival, so on average 48 months before people progressed on immunotherapy versus 19% at 2 years versus chemotherapy. and there was a non-statistically significant trend to people having better overall survival, which makes sense because people just do better. And obviously the fact that it's better tolerated than chemotherapy, it's not perfect. There are some people that do have side effects to it, but far less than the toxicities associated with chemotherapy. Which brings me to the ASCO 2025 update. And what was presented was a clinical trial, a phase 3 trial, looking at a combination of two immunotherapies together, nivolumab plus ipilimumab versus nivolumab alone. And nivolumab and the pembrolizumab I just showed you are equivalent in how they work and equivalent in how successful we are with the treatment and how people respond. And what we found adding these two together compared to the one is that the progression-free survival was 54 months versus 18 months, and adding two together didn't add a huge amount more of side effects, and it's now considered the preferred combination. I thought I had a slide to show the difference, but I believe I left it out. But for me, in my healthier patients who can handle the potential acceptable increased risk of some side effects, I'm clearly going to give them the nivolumab and ipilimumab over the one agent alone. If it's someone who's a little bit older or has other health issues, then I'll give that single agent with the confidence that it's still 5 to 6-fold times more effective than chemotherapy. I'm going to shift to immunotherapy in early stage rectal cancer because this data is data that we've never seen before in clinical trials. I mean, it's just unheard of. This was presented in the New England Journal of Medicine. This was a trial that was driven by the team at Memorial Sloan Kettering, who I kind of defer and prefer and refer to them as the gurus. They're the cutting edge right now of immunotherapy and research. They took individuals with early stage rectal cancer, either stage 2 or stage 3, and they gave them immunotherapy. And the way that we typically treat early stage rectal cancer right now, the standard of care is 4 months of FOLFOX or FOLFOXIRI, so 4 months of chemotherapy, followed by chemotherapy and radiation, generally for about 5.5 weeks, followed by surgery. So, at the end of the day, it turns out to be about a year of therapy. And at Sloan, they gave the immunotherapy, and what they found is that 100% of their patients had a complete clinical remission with just immunotherapy. Their cancers were gone, and those patients did not have surgery. So, the feeling is these individuals can potentially avoid the long-term issues from surgery and radiation. I mean, certainly there's some uncertainty with the long-term outcomes, but we're 2 years out now, and they have multiple more patients who have been enrolled on this trial, and many more that we've treated that are not on the trial, and they have not had a single relapse, which is just absolutely unbelievable. So, obviously, if we go down this path, people need to know that there is a risk of side effects from immunotherapy, and there's a very small risk of fatal side effects that can't be underestimated. And people who are treated with immunotherapy need very close follow-up and more invasive follow-up than you would need otherwise. A pelvic MRI, a digital rectal exam, a sigmoidoscopy with biopsy every 4 months for at least a couple of years. But in my mind, it's a small price to pay if you can avoid, radiation and surgery. So in this trial, it was the immunotherapy every 3 weeks for 6 months. Again, 100% response rate and not a single reoccurrence up to this point. And I put the slide up to show the same thing, but you could see the vast majority of people on this trial had lymph node involvement. So these were stage 3 rectal cancers. These were not just very early rectal cancers. So, people are responding quite well. And I will tell you that they've had some patients with advanced colon cancer that have had similar results. And I put this slide up here just to show you that complete response, that darker blue line happens relatively quickly. it happened anywhere from 3 to 6 months into treatment, which is pretty astounding. So how has this impacted my treatment personally? Obviously, with the advanced disease, it's standard of care. I saw a gentleman this week who came in, had advanced disease. He was in a huge amount of pain, and with one dose of pembrolizumab, pain-free, and he's been controlled for over a year and a half. He's going to Arizona to golf this weekend, and guy feels great, which is just it's so rewarding to see with no toxicity how well people do. I said the second point here is number 14 on the Sloan Kettering trial, because a week after that trial was presented in the New England Journal, I met a young guy in the community with an early stage rectal cancer who on his own did the research and found out about this and flew himself out to Sloan Kettering, and he became patient number 14 on the trial. And I, in fact, got a message from him today that he's due for his Signatera test, but he's in that 100%. He's not recurred, and he's 2+ years out, and has done remarkably well, and we believe that he's been cured. And the most rewarding example for me is a patient of mine who is a young individual who has Lynch syndrome but didn't know, and presented with advanced colon cancer. And it was right around the time that this data came out from Sloan Kettering, albeit data for early stage rectal cancer, and he was already stage 4. And it was a tough discussion because the standard of care at that time said, I should just give chemotherapy, but I had this immunotherapy that I knew was 5 to 6-fold times more effective, but it wasn't standard treatment. And, I had conversations with the patient and with the family, and I said, this is kind of what my gut's telling me we should do because I know it's going to be more effective treatment. Why don't you go to a couple different areas? We're in Chicago. We have Northwestern. We have Loyola. We have Rush. We have UFC. We have true academic excellent centers. And he went to a couple different places, and they said, we wouldn't give you immunotherapy because we don't think the data's there. And when they came back, we sat down and we had a heart-to-heart, and I said, they're right. I don't have the data, but you're going to respond better to this. And, 2 weeks ago, just finished his 2 years of immunotherapy, cancer-free, PET negative, Signatera negative. I actually sent him to Sloan so we can get their opinion and get some recommendations on what kind of surveillance. And they believe that he's cured without the need for any surgery, which is just, it absolutely blows my mind. It's just, it's such an exciting advance for the patients who could benefit from it. So, hopefully the dog did not bark, which it was absolutely a shock. I thought maybe I did put him to sleep with the talk, but I do want to open it up for questions. Happy to stick around for as long as you need me to be, and hopefully you found this talk somewhat beneficial and kind of got a sense of how things have evolved from where I started 20 years ago in my practice to where we are now, and some of the exciting advances that we just learned about even a couple of months ago.
Thank you, Dr. Adas. This was a really informative lecture. Before I unmute everybody and stop the recording, I will read the couple of questions that came in via chat first. One is question regarding Signatera test versus circulating DNA. Is this something that you would recommend for stage 4 rectal cancer? For some context, 2.5 years post-recurrence relapse. Sounds like science is saying that that this test is something to do overall in all stages. What is your opinion?
So if we're 2.5 years post successful treatments and there's not been recurrence, on one hand, I would say the prognosis is great, obviously, fortunately, because the highest risk of recurrence is in the first couple of years. So is there a need to do it 2.5 years out? Probably not going to give as much information as it would have 2.5 years ago when we stopped or when we completed therapy. But there are some people that come in and say, listen, for my peace of mind, now that I know that that's out there, I want you to start monitoring this. And it's a test that I have ordered in individual situations. I think it's not as necessary, fortunately, 2.5 years out, but not absolutely, something that can't be done or shouldn't be done.
Thank you. And can you talk, you mentioned the side effects of immunotherapy could also be pretty severe. Can you talk about the difference between the side effects of immunotherapy versus chemo?
Sure. Chemotherapy, I think that unfortunately most of us are well aware of the side effects that come along with it. Fatigue, suppression of the immune system, the potential for nausea, vomiting, the potential for GI issues, diarrhea, constipation, peeling of the skin on the hands and feet, hand-foot syndrome, sores in the mouth, hair thinning. If you get oxaliplatin, the risk for neuropathy. Those are the main side effects that I think about with chemotherapy. If you add medicines like cetuximab or panitumumab, the risk for more diarrhea or the what we call the acneiform rash or rash. Avastin, high blood pressure, kidney issues, the smaller risk of perforation of your bowel. That's like the standard what I think about with chemotherapy. With immunotherapy, the vast majority, you won't get any of those side effects for the most part with immunotherapy. What happens with immunotherapy is essentially what we're trying to have happen. We're trying to unleash our immune system to attack the cancer, but sometimes when that happens, it can attack normal areas and lead to inflammation. So, for example, it can cause inflammation of the GI tract and cause pretty severe diarrhea. It can attack the skin and cause a pretty significant rash. It can attack the lungs and cause inflammation and shortness of breath and cough. I've had individuals where it's called it targeted the retinas and caused inflammation of the retinas, which is kind of a funky manifestation. The other interesting thing that it can cause is endocrine issues. It can lead to things like diabetes and thyroid disease and pituitary disorders. Now, those you're not necessarily going to feel, but the standard is that your physician should be monitoring that very closely, and they should be easily be able to detect that. We're getting a lot better at the management of side effects of immunotherapy, either with steroids or with other type of medicines that we can add in to try to minimize the severity. But there are, just as with chemotherapy, there's a small risk for more significant issues.